Well, welcome. I'm Joe Bormel, and I've been asked to do a presentation on AI in healthcare by the David A. Winston Health Policy Fellowship. The presentation is intended to provide a framework and subsequent discussion for the 2024 Winston Health Policy Fellowship awardees. And the slide deck is intended to provide a broad and ambitious orientation to that topic. Many of the slides are detailed, and the details are really for future reference only. They're not for reading today. And this deck was drafted with artificial intelligence assistance, primarily using large language models. How it came about was I got a call in July of 2024 at 11 a.m. and I was asked by the executive director for the fellowship if I could do a presentation on AI in healthcare. So I went to the large language model. I told it what I wanted is a one-shot query. It came back with the following options or approaches that I could take. I wanted to take something that was pretty close to approach 3, the stakeholder perspective, and that specified the key elements. But if you are attending any AI in healthcare seminars or webinars, of which there's at least one a week now, and there have been for the last year plus, almost everyone follows one of these approaches. So it was interesting that it was able to present those options, and it aligns with how the universe works. I sent the agenda back, which looked like this, to that executive director, and I said, hey, if I did this presentation, would I be meeting your needs? And he said yes. And so here is that presentation. I've done it now about a dozen times, gotten a lot of really great feedback. I've modified it, improved it as a result of all that. This is going to take about 45 minutes, and there are sections that could be presented over an hour by themselves or a day by themselves. The whole deck could be done over the course of a week. So this is gonna be ambitious. So my background is I'm a Harvard and Hopkins trained physician. I'm board certified in internal medicine. I've done a rheumatology fellowship with very, very sick patients at UCLA, vasculitis, lupus, rheumatoid arthritis, things that are hard to diagnose, things that are difficult to treat, often require chemotherapy. I've worked in regulatory science in several agencies of HHS, including the ONC, and I've done contract work with the FDA, with the CDC, with SAMHSA, and with other entities, also the Veterans Administration. I've worked for 20 years in the electronic health record industry as a chief medical officer and VP for product management at Oracle Cerner and at Quadramed, and I have an MPH from Harvard in public health clinical effectiveness. When you think about artificial intelligence, there's a wonderful recent book that came out by Juliet Powell and Art Kleiner, and they point out that this is sort of my way of describing it, but they call it the 4 logics of power. This is from them. There are people who approach artificial intelligence from an engineering perspective, and they talk about machine learning, and they talk about Python, and they talk about clouds and all kinds of engineering kind of technology kind of approach to things, and GPUs and NVIDIA and all that good stuff. There are other people who talk about artificial intelligence from the standpoint of a corporate logic in terms of who's going to own it, what markets are there, how to grow in those markets, and who the competitors are from that perspective, and what cloud service providers are there, and what things have to be done on a unified platform and which things can be done in a pipeline, and all those kinds of issues, and how to access markets and how to create the enclaves necessary to achieve the multiple dimensions, what has to be done. There's a third kind of a person or orientation, or one of the logics of power, which is the social justice logic, and to recognize by using artificial intelligence, what are we doing? What's the impact on society? What's on humanity? What's going to happen to jobs? What's going to happen to people's rights? What's the issues with biases? And it's and typically these people are equally deeply trained and detail oriented as the engineers and the MBAs and the other two boxes we've talked about, but they obviously have other primary concerns to the bits and bytes or the dollars and cents and market domination of the other two groups. And the fourth group is the government logic, which is what authority and security needs to be put in place on a society basis to ensure that that there is safety in the same way that we have the FAA provides air safety and we have clean water and clean air, and those things don't happen without the government logic piece focusing on that. And with artificial intelligence, as it's suggested at the very bottom, we're moving from technology as tools to machines that can make life or death choices. So there's agency is one of the terms people use around this. And for anyone out there who has either driven or driven in a Tesla with full self-driving mode or in a Waymo, these cars are making decisions. And even when there's humans in the loop, there are times when the machines are making life or death choices. We just got a Tesla in my family about a month ago, and for everyone who has one, you know they do great. They can do great things when they're just on the highway and there's clear conditions and everything is well marked and everyone is playing by the rules. And as soon as you start to get into people being stopped on the side or having detours or and a lot of other conditions, they can completely drive off the road quite happily, not recognizing the larger context. Part of addressing AI in healthcare is what do we mean by healthcare? And for me, for my medical training, I think of healthcare in terms of when patients get really sick, they go to the emergency room, and when they're really sick in the emergency room, they're admitted to the hospital, possibly in the intensive care unit, and there is some number of inpatient days, and there's some sort of a transition to home or to post-acute care. And so for me, there's doctors and there's nurses and there's therapists and there's modalities and there's all this intense stuff. And that is one aspect of healthcare, and that's an aspect where artificial intelligence can have a role. But as you can see from this image, AI in healthcare may also reflect the things that are done with healthcare data and to drive getting things done that need to get done, like vaccinations, immunization, preventive care issues. There's artificial intelligence that's being used in mental health and behavioral health, and these things have become absolutely critical. And there's prescription digital therapeutics being used on mobile devices for behavioral health that are very, very effective. They've gotten FDA approval, and in many cases there is no alternative way to provide some of those services because we don't have enough providers. We saw some of this in during COVID, but it's a broad issue. So what you're seeing on that is a couple of dozen areas of healthcare where artificial intelligence in healthcare may have some very, very, very important and powerful impacts. And as you can see there, some of them are wildly different from each other. And again, we could talk about any one of those for an hour at a time. What you're seeing here is that the large language model that was involved in this, I asked it what is the focus or emphasis for each health category from the political left's perspective and the political right, and then rank them from areas where there's the most consensus to the least consensus, so that's the table that you're seeing. So hopefully this gives you a sense of the waterfront of what we might be meaning by healthcare. One of the things that is not only fashionable but really quite critical whenever we have any kind of a presentation on healthcare is a reminder that healthcare is different from every other industry. And certainly in areas like, for example, financial accounting that uses data and using artificial intelligence, healthcare tends to have a lot more dimensionality. And you can see an elaboration of exactly what that means in terms of the types of measurements on the picture on the left-hand side of the screen, and some of the other fundamental characteristics. And then the specifics, the key aspects of the curse of dimensionality include sparsity of data, exponential growth in data requirements, increased computational complexity, etc. And there's a lovely article that elaborates all of this, and you can see the link to that here. An article that came out while I was doing this presentation came from Eric Topol, who's written several great books in healthcare and has a great Substack, and he did a Substack that just came out last week about what can 11,000 proteins in our blood tell us. Strongly recommended article. The body's expression of proteins happens in spikes, and it's related to certain ages. There's all kinds of things that we know now, and the amount of data that is contained and would need to be reasoned over with machine learning and self-supervised learning is including more and more data elements every day, and we already had the human genome before that. Protein expression goes beyond the proteins that are coded in the genome, but then are expressed based on a tremendous number of different factors. From that article, we have and articles like it recently. We have not just proteomics, which that article talked about, and genomics, which probably everyone in the audience knows about and recognizes this is a huge opportunity for AI in healthcare, and this is a degree of reasoning we couldn't do with purely human power in 24-hour days and without computers. There's a variety of kind of other omics that also produce large amounts of data. Probably one of the ones that is most exciting to many people is the microbiome that's found in the gut. This comes up with a lot of people, and it drives diseases and can influence effective therapies. And exosomics, which is looking at exposure history and cellular communication based on bodily fluids, is another one of these areas that's incredibly important and new and highly relevant. It's a big chunk of some of the recent legislation with the VA looking at the impacts of exposures on the military, etc. Again, this table is designed to be read later, but it elaborates where each of these omics, where we're getting the tissue, blood, etc., to collect the data. There's exemplary conditions, and then there's an estimate in 2024 costs, and based on availability of data in 2024 in terms of what's in the panels of tests that we do, what that costs today. So you can see that there's a lot of that testing that can be done for under $1,000. Again, fairly new capabilities, and with the use of artificial intelligence, this has the potential to dramatically improve our ability to diagnose as well as to prescribe the appropriate effective therapeutics. You really can't talk about healthcare and improving healthcare system without calling out that there's inherent contradictions in the healthcare system. The healthcare system isn't a system. Healthcare market isn't a market. J.D. Klenke's book, Bleeding Edge, made that really clear for me about 20 years ago. We're going to come back to this concept. But the net of it, the take-home lesson is, if it doesn't work, if we don't know how to solve it without technology. Adding technology is, in most cases, not going to provide a solution because the limitation wasn't a lack of technology. So basically, as you saw from my original agenda, the issue of goals and stakeholders as a way to think about artificial intelligence is really the crux of this presentation. And so you'll see that going through this. So in terms of what kind of goals do people have in healthcare, you have these goal categories here. The top one, based on likelihood of us getting improvements with artificial intelligence, is advancing disease prevention and early detection. And you'll see a case study on that in a moment. There's other goal categories. And then just for both completeness and to strike a resonant chord, most people who I know who are over 50 or over 60, their biggest interest in healthcare, if they're healthy, is to improve longevity. And so I wanted to include that on the list. That's not one of the areas that is likely to have a dramatic, for artificial intelligence to have a dramatic impact on our lives in the next 2 to 5 years. So, and again, these slides are to provide you an orientation and something to go back to. Also, I'm not an advocate of having federal appropriations to fund all of this. There's a lot of different structures for achieving a lot of these goals, and a lot of the things that have been relied on congressional funding. For example, the NIH All of Us research program has in recent time gotten into challenges because there's been a reduction in that funding, and congressional appropriations are sometimes necessary, but often not sufficient in terms of structurally how to pursue these kinds of goals. That's kind of an aside from today's talk, but worth mentioning in passing. One of the goals that, especially from a policy perspective, that artificial intelligence may help with is reducing wasteful U.S. medical care spending. And so there was a nice literature review. There's a link at the bottom to the URL discussing the review of the best articles in this field. But essentially, there's an opportunity for AI to improve clinical efficiency, to identify missed opportunities for prevention, to address overuse, to address administrative waste, to address excessive prices and price transparency, and a lot of other issues associated with pricing and fraud and abuse. And so I wanted to call out that this is one of those places where AI very well could be directed and could produce tremendous benefits, and it actually may be very well suited to it for a lot of reasons. So again, because it's so important to think about where AI can impact health, I'm offering what I'm calling the class model. I made this up, so you won't find this somewhere else. But it seems to me as a provider that there are 3 basic classes of patients and their types of presentations to the healthcare system that we see as doctors. Class 1 is a patient coming in with a known problem like hypertension or bleeding or their hair thinning or fatigue. Could be a weight loss, could be any one of these common known problems. And the kinds of diagnoses and the ways to treat that are things that we do every day and we're very familiar with. And in this class 1, it's likely that we can help the person a lot. Our ways of improving cardiovascular disease with diet, exercise, screening, cardiac calcium CT scans, various kinds of surgery, etc. Generally very, very good prognosis. And the impact of artificial intelligence for this class 1 is to augment human performance, because we kind of know how to do it. We can enhance triage, we can automate documentation, we can do better decision support. We can help take some of the friction out of the current system. where that friction is just the time it takes to get things done, or the mechanics of it. There's class 2 is where people come in and they essentially have a really bad prognosis. There's not a lot we can necessarily do for them. I've lost friends and family members to pancreatic cancer. That's a classic example of a class 2 situation. I also have lots of friends and family, and so does everyone in this audience, with Alzheimer's disease. I literally have a half a dozen friends who've been diagnosed with Parkinson's in the last 2 years. And so it's not necessarily a poor prognosis, but it's progressive, and we don't have effective treatments right now. And the impact of artificial intelligence in that area might be to refine palliative care and help identify clinical trials and enhance communications. I would not expect for class 2 problems for artificial intelligence to have dramatic impact in the next 2 to 5 years. I think some of the false hope that's been sold through AI in the past, IBM Watson comes to mind, are examples that we really need to sort out the different classes of things that we're addressing, whether or not we can solve them without technology, whether we have the data and the science and the likely path to cure by using, or to hope by using, artificial intelligence. And then there's class 3 stuff where we have uncertain diagnoses, and despite investigations, we have unpredictable prognosis. And in those cases where you have the unknowns, the opportunity for AI to provide a lot of clarity and provide significant impact is probably minimal. And so I think it's important. I think there's a tendency for people to try to apply artificial intelligence to areas where they have a lot of knowledge and experience and hopefulness. And so, for example, a friend of mine heard about my presentation. He said, "Oh, you're going to talk about how insurance companies can improve their operations using artificial intelligence to classify claims and do all the things they do." And the answer is that's absolutely a class of things that one can do, and it's already being done in those spaces, and it makes sense. It may not have the impact on. It probably has no impact on class 2, and probably has not a lot of impact on class 1, because class 1 is not necessarily limited or gated today by issues that artificial intelligence helps. So I wanted to offer a case study, and the case study is probably the single biggest area where AI can help today, and that's computational pathology. And as it shows here, they were able to detect all forms of cancer, pan-cancer detection, with significantly higher levels of identifying 9 common and 7 rare cancers. The impact of doing all of this is a Nature article that was published in July of 2024. The benefit of doing this, and the company Page AI, who's been working in this space for years, is they show huge benefits in faster diagnoses, increased accuracy, cost effectiveness, improvements in consistency, and in support for pathologists. All of these are 2 to 10x improvements. So just absolutely huge, amazing stuff. And I highly encourage you to take a look at that article. It's really quite incredible. The potential for far better results from human diagnoses is shown here. As part of the feedback as I produced this presentation was that you got to be careful when you're projecting better results for cost, because upfront costs are different from the fixed costs of rolling them out, which is different from the marginal costs of seeing the next patient, which are dramatically lower, but they infer the higher upfront costs and the issues of urban versus rural rollout and implications are really significant. So this is just a great case to think about in terms of understanding the dimensions, and I'll say the waterfront of artificial intelligence in healthcare. One of the things that worries me as a former business executive is this technology is already having disruptive impacts and is likely to have disruptive impacts. And also broadly in society, there's been a lot of discussion on so-called P-doom, the probability of doom from artificial intelligence, based on a lot of things, but reducing human labor input, and with the resulting need for things like universal basic income. The disruption that artificial intelligence will have if it rolls out as we understand it may is really quite huge. And so I decided, why don't we look at what are the potential disruptive impacts of AI in healthcare? And so what you're seeing here again is I asked a large language model, please tell me about the major disruptions that AI could cause in healthcare. Tell me the impact and describe them. Look at the likelihood and probability and timing of when these things would have an impact if they were adopted, and what kind of government regulation is likely to be proposed, and what are the likely impacts of that legislation. So again, this is a great opportunity to go back and look over and get some ideas of what the scope of AI in healthcare can do. We talk about AI as though it's a simple, it's one thing, and it's not. There's basically 4 AI performance task categories. You can replicate things that are done by humans. You can augment humans in doing things. You can automate tasks that humans traditionally did so that they can happen faster and with greater consistency. And then you can do tasks that were previously impossible for humans, and that's the innovation category. So there's examples and healthcare examples of all those things here. And when I was doing this presentation for a senior VP for regulatory compliance for a multi-billion-dollar health IT company, he pointed out that automation addresses human fatigue. We get slower and we get less accurate when we're tired, and we're making people more tired. We're putting more stress on people. Plus, we're distracting them more with phones and with things like Slack and other distractions. And so, this ability to address human fatigue, automation through automation with AI, things like robotic process automation, in the short term are likely to be some of the most powerful benefits. For those of you who want to talk to me privately, I've been using remote process automation actually for doing things like making this slide deck. So there's the high view of the high level overview from this presentation is that AI does 2 big things in the analytics space, which is they help us find cohorts and make predictions, and they do it in ways beyond what was using machine learning in ways that traditional statistics could not get to this level of precision and speed, and dealing with the subsets to the degree that large language models, that machine learning can do. And then generative AI provides summarization, which is a huge benefit. It may not be quite as magical in terms of doing just the gymnastics of dealing with the data work in analytics, but the summarization is huge. It's highly valuable. We're going to talk about 9 capabilities that AI expresses in healthcare. We're going to talk about the other things that are shown on this slide. And the very last bullet here, the alignment of healthcare interests did not exist before the advent of AI, and it's unlikely that those fundamental issues with incentives are likely to improve all by themselves or simply by applying AI. So shown here are the 9 intelligence capabilities of AI. Predictive analytics we talked about. It's very excited. The anticipated impact is one of the highest ones, as you can see. The impact on lives and the impact on dollars are both very significant. And then again, because one of the primary audiences for this presentation was health policy fellows, I put in the column with the sensitivity to legislative activity. Personalized medicine is next, and you can again. There's a limit to what one can do in an hour. These are major capabilities, and they're sorted by anticipated impacts. Each one of these capabilities, many people, this is their wheelhouse. They're very, very excited about it. So some of my friends who are in the space of virtual health assistants, they are most excited about the promise of AI in healthcare in that space. And so, although these things may be lower on anticipated impact, it doesn't mean that that they're both not important. There's not going to be niches where they're important, and also beyond that, for some populations, some of these things are going to be absolutely critical, and they already are. And we could go long in terms of how these things roll out by the states as well. There's a tremendous appetite and need in California, for example, because of not having enough behavioral health counselors to be doing some of these things like virtual health assistants. So I talked about these 2 analytic areas, finding groups of interest and predicting future behavior. This slide just elaborates exactly what that means. And the last example here, pathologic diagnosis from images. This is the case study that we did. I did want to just quickly, in the remaining 15 minutes or so we have left, just alert you to some of the key elements with AI in healthcare, and they're listed here. The first one is that AI can refer to several distinct things, and so those things and their definitions and examples are provided in this slide. Sometimes people say AI and they really mean machine learning. Sometimes they say AI and they really mean natural language processing, etc. And so it's important if somebody says AI and you're not completely sure what they're referring to, you really need to ask them, and hopefully they'll give you something that lines up with one of these definitions where you can drill them further at that point. The term itself has some ambiguity to it. Some people use AI to imply imitation of human intelligence. And also, people often, different sources use AI aligned with what their institutional objectives are. So Stanford defines AI in terms of science and engineering of making intelligent machines. IBM talks about mimicking problem-solving and decision-making capabilities of the human mind. NIST has their definition. Harvard Business Review is looking at opportunities to do the kinds of business re-engineering that you would associate with Harvard. The World Health Organization, they're actually thinking about this in terms of approximating human cognition to deal with analysis of complex medical data. And McKinsey, of course, is thinking about, is focusing on how these machines can perform tasks that normally require humans. So they are looking at right-sizing workforces and workflows, et cetera. And I'm sure that organizations like BCG, Boston Consulting Group, Bain, et cetera, have similar aspirations for how to use AI. The relevance to healthcare is elaborated. The things that I've highlighted in yellow are particularly important and, again, worthy of at least 10 minutes of discussion on their own, which we don't have. I did want to orient the audience to the issues of data. And one is that in healthcare, we have structured data. Most often, this is claims data because that's what's needed for reimbursement. And that's a requirement. And everything beyond that is often not a requirement. And so in healthcare, we have a lot of structured data. It is high cost. It's relatively high effort. The accuracy is high within its coding schemes. It produces a moderate amount of provider fatigue, and generally speaking, the interoperability concerns are low in that, in the ICD-9 world, if it was diabetes, you were probably going to call it 250.00, which is diabetes not otherwise specified, and that code is going to be used with similar frequencies by different provider organizations. And there's a small number of codes that are in pick lists or that providers have memorized or that are commonly used by payers, by health information management and revenue cycle parts of provider organizations, because they are the codes that are the best reimbursed. And so those are the ones that are selected if it's at all possible. In healthcare, there's a lot of free text. It's unstructured narrative or notes within the ER, not codified, difficult to analyze. It has different issues as far as cost, effort, accuracy, provider fatigue, and interoperability, or interoperability concerns, I should say. And then there's a couple of domains where there isn't data, and this is one of those areas where you talk to people, CEOs who have done startups, and they were really surprised that they couldn't get data that they thought they could get. And in some cases, the data was never collected. In some cases, the data was not released by the primary vendors, the Oracle Cerners and the Epics of the world, for whom they have their own applications and services that use that data, and making it available is not aligned necessarily with their business interests. It's also true for provider organizations. So the issue of data is a very, very important consideration. Data is used in healthcare and care delivery, and it's also used in research. So sometimes called life sciences. So this is the trials before medications are approved for use in care, or they're used in public health, etc. I've identified that there's 5 domains of healthcare elements. There's person and plan information, there's health concerns, there's goals, interventions, and outcomes. I thought this was all pretty cut and dried and straightforward, and I was humbled by the feedback that I got. It was quite correct that there's a politics of healthcare, and that some of the issues of that are surfaced in the purple text below, and again, we can come back to that at some other time. But it is important that terms like social determinants of health are not recognized by half of the political spectrum, or not recognized as major considerations. Health and Human Services last year came up with this term, health-related social needs, to try to get around some of the politics of this, and a elaboration of those issues is there on the yellow pane on the right. For any disease area or clinical condition, there can be different things that determine the diagnoses and the treatments and the efficacy. And so what's shown here, courtesy of Heather Flannery, is the elements, both environmental determinants and individual determinants in obesity. And if you look at it, they'll make complete sense to you. And you really can't address obesity without knowing a little bit about each of these cubes in your patient, and have that influence whether they're going to be appropriate for bariatric surgery, or for Wegovy, or Ozempic, or pure dietary interventions, or whatever. And this whole aspect that the amount of data that you need to adequately and competently characterize the situation for AI, I think, is nicely illustrated by this picture. There are 8 processes that comprise workflow. Whenever a patient is seen, inpatient, outpatient, in consult, whatever, it's critical that that 8 things happen, generally in order. The patient is identified, their needs are assessed, there's plans based on their needs, there's orders based on the planning, there's scheduling that's done, there's performing what was planned, there's documenting what was done and accounting for that. Same thing happens in a physical therapist's office, as in an ER, as in a primary care provider. Same thing happens in when there's referrals for housing insecurity, food insecurity, transportation insecurity, etc. These are just fundamental issues, and there's generally data elements that are ideally captured, ideally in a structured way, for AI to reason over and provide its magic. This common process map provides some drill down on the fractal nature of what's implied by each of these 8 points. This is just a slide to kind of help you understand how this relates, for example, to the Medicare population. Artificial intelligence in healthcare, if it's going to have an impact, is going to be directed at hypertension, heart disease, and arthritis as just the top three prevalent conditions in the Medicare population. And in terms of the annual cost to the U.S. in billions of dollars, those are shown here with the top 3 shown in green. So again, I'm just trying to make the connection that data is really important, that the scope of things that we need to cover and the impact on how much we see it in patients and the impact on costs is all very, very high. And to make the point in passing that care suffers when data is inaccurate, incomplete, inconsistent, duplicated, or non-current, which in many cases in many situations is the case today. So in summary of the problem and the opportunity, I think Elizabeth Rosenthal's quote is most helpful. In no other industry do we see the same mix of government and private players operating under conflicting incentives and rules. And so that's a key aspect. I think getting back to my, in closing, my fundamental premise is that you really have to think about what goals we're trying to achieve, or objectives, just use a different word for that, and what are the constraints on achieving those goals. And in agriculture, for example, the goal might be to maximize profit through input choices of how much corn versus how much wheat to grow in our 100 acres of land. And decisions we can make is whether we're going to have 90 acres of corn and 10 of wheat, or the other way around, or just do 10 of each, or whatever. But those are the decision variables. This is called operations research. And then you've got constraints. So how many acres do I have totally to use? What's the minimum is a requirement? What's my maximum capacity? What's my available supplies like water and labor? And of course, I can't grow negative 50 acres of corn. That makes no sense. So this just shows you can reduce data and bring it all together in terms of an objective. And this example, I learned this when I was in my master's program but I think it's just very, very clear. The same framework of objective function and decision variables play out in healthcare, and that's what AI would be optimizing or automating or innovating on. And so the types of things that you can do are to try to minimize the cost of an episode of care, or maximize hospital profitability or length of stay. So here's the data you would need to do that. Here's example calculations, and then here's the scope in very, very specific terms. And these are the kind of things where artificial intelligence could be selected because the current state of performance within a hospital or a provider's organization or for a patient might be 10%, and it might be possible for it to be 90%. And so you have to get current state data. You've got to know what is the best that's being achieved. And then potentially in those places where AI can help close that gap, that's all very exciting. I came up with this, and I did a little bit more research, and I discovered that the whole topic of constraints in healthcare is actually pretty well studied. And so the constraints are market distortions, insurance inefficiencies, structural issues, like fragmented healthcare delivery, misaligned incentives. And so there's the reasons for those things, there's the explanations elaborated here, and then there's the sources where the large language model found, and with specific links to those chapters or books that are specific to that topic. When you look at constraints in healthcare and some of the things we've talked about, they are explained here, and then they're elaborated in terms of potential AI impact. So I thought this was kind of, again, nice because it helps make it very, very, very clear the details of thinking through AI in healthcare. And you can also ask the large language models to estimate the impact level of doing some of these things and sort things out based on that. So you can decide where to start with high-level things like price transparency and the issue of I've done some work with cost transparency with or price transparency with Aetna and a company called WellMatch, and with other companies, and I've been in contact with folks with United Health Group and with Elevance, and so these are areas that are major opportunities to improve healthcare. As a simple way of looking at things, if your initiative or your goal-based objective is good for business and it's good for the health of the patient, that's just a win. If it's bad for both, that's just a lose. And in these other combinations where it's bad for business and good for health, it's, from a business standpoint, it's a non-starter. If you're a publicly traded company, you're obligated to maximize shareholder value and profitability, and so you're not going to do things that are bad for business, with the minor exceptions of B Corps and triple criteria, which are out of scope for today's conversation. There's also areas that are good for business and bad for health. Arguably, a poorly implemented prior authorization program would be a great example of that. Again, the slide deck is not to be read now, but here's an elaboration for each of those cells, what the major opportunities with AI and how they kind of impact medical costs and patient satisfaction. The major stakeholders, here's an example of 4 and what their interests are. Very, very readable. If you're interested in that, you can actually expand this quite a bit to include, for example, care coordinators and pharmaceutical industries. And often the trade-off of what's good for one and bad for the other is a big deal, and they're highlighted in the particular cells here. So with the pharmaceutical industry, if they could focus on something that was curative versus preventative medicine, that may reduce long-term profits from chronic diseases. And so in terms of their objectives, they might be more focused on something that was more like a statin than something like a drug that you take once that activates a gene. For example, it would have a different profitability expectation. And it turns out when you start to do that, you realize you actually have to group the patients even a little bit more, because people with chronic diseases have a different interest than people who have emergency needs, and it's a little different than episodic and preventative needs. And the same thing is true for different types of providers. So if you're going to be introducing artificial intelligence and you're going to be focusing on specific goals and objectives, clarifying which stakeholders you're serving and whether or not there's, once again, that gap between current state and potential benefit state requires you to think down at this level. There's the alignment problem in AI, which is elaborated here. In the interest of time, I'll let you come back and read to it. If you're not familiar with the alignment problem, you should come back here and read the slide. The paperclip maximizer, the HAL 9000 computer in 2001: A Space Odyssey. There's examples. There's where artificial intelligence can do things that are not consistent with human values and do that without that being the expectation or plan. It's important to mention that there are a lot of issues and challenges that we didn't talk about today that are really important. Data privacy and security, ethical considerations, etc. And you can see them, the definitions here. You can see the context for AI. And you can see different examples. And again, I've spent 10 minutes when I did this, went through these with the fellows, and then we spend an hour after the talk talking about some of the drill down issues. One of my favorite ethical issues that comes up with genetics is if a person gets diagnosed with Huntington's disease, is that person obligated to tell their family? And there's a form of anticipation or an accelerated form where somebody might get diagnosed with Huntington's in their 30s, and that actually translates to a risk of somebody in their family, maybe a cousin, getting it in their 20s because of the way that genomics works. And so should that person who gets diagnosed be obligated to tell their family who might be doing family planning? So this is not specific to AI issue. However, as we increase the amount of data we collect, because we can use it, and we do use it, and we have increasing personal data estates where people are using 23andMe and getting this kind of information, these ethical issues they come along with the package of considering AI. I mentioned data quality was important in my slide talking about Medicare. I did a lovely presentation at HIMSS, got a lot of positive feedback in the clinical architecture, data quality theater. And so that's me. That video is on the internet and YouTube. And the point that human decisions aren't discrete, rational ones that you could use clinical decision support isn't always the case. There's decisions in any organization often flow from hierarchy. There's often issues with flow of knowledge. For those of you who've read Yuval Noah Harari's book on Nexus, networks and knowledge networks are hugely important, and they transcend the issue of making decisions based on data using artificial intelligence. There's core group issues, and there's how work flows, for example, from the VA to Kaiser or to a local academic medical center and then back into the VA is a very, very challenging area. Some great work done in that space. And so you have to recognize that AI and traditional decision support is one lens. It's not the only lens, and it may not be the crucial lens in your organization. And then we really wouldn't be a complete conversation unless we mention that there is bias in data. There's cognitive bias, there's data limitations, sampling errors, systemic prejudices, etc., and technological limitations. So those descriptions and the AI healthcare examples are elaborated here. And then one of my learnings in closing was that there's political values in healthcare that I didn't realize. I was trained in a Western and somewhat liberal healthcare system where social values are pretty high, and holding people accountable from a self-responsibility for healthcare issues is a weak or absent value on the liberal world. And so some of the things that I said in the presentation already are a little contentious for some groups, and you need to be aware of that. So for example, something like obesity, the issue of having strong government intervention through taxes, labeling, and public health campaigns to reduce obesity might be, from one political viewpoint, absolutely necessary. It might be completely repugnant to another one. Two of the major tobacco manufacturers went into making what some people would say are more addictive foods, which lead to, for example, obesity. And from one political spectrum, that's horrible, and from the other political spectrum, that's people have self-responsibility and autonomy, and the government should not play in that space. And so the same thing happens in cardiovascular disease and in cancer. And so those major features are elaborated in the slide. And once again, I only asked a large language model to please elaborate those features and describe it for obesity, cardiovascular disease, and cancer. And obesity is a stand-in for metabolic diseases, so diabetes type 1 and type 2 is in there, and other issues. Also not included, just for brevity, is neurodegenerative conditions, but that's another big one that impacts quality of life at high numbers. You can actually look at some of these major features from the left political, right political, centrist views in terms of what they think is the appropriate actions to consider. And you can see that, for example, soda taxes on the left is a strong regulation. Some of you may remember in New York City, the super drinks, they were taxing or banning those drinks, and that's clearly a government intervention. If you take a look at this just from the standpoint of using large language models, you'll see this is very cryptic. It's just sort of 5 words here and maybe another 5 words here. You can actually tell the large language models, please describe these in something closer to complete sentences. And so without doing anything other than giving that prompt, it expanded this into that this represents strong support for government regulations and programs to combat obesity, such as taxes on sugary drinks, mandatory nutrition labeling, and public health campaigns. And the example actions is implementing soda taxes, subsidies for healthy foods, public health advertising campaigns, etc. So I got a lot of feedback that people enjoyed the fact that I used the large language model and kind of showed them how I used it to get some of these results. And this is actually, I think, my last slide before my thank you slide. Essentially, this gets back to this left, right, and Trump politics. It's currently October 2024, so we do have the election coming up, and the 2 major candidates are Harris and Trump. And it turns out that the Trump perspectives don't, according to large language models, don't match those of traditional conservative right-wing politics in every case, or they're more defined, or I'll say perhaps refined. And so the core values of liberals is to prioritize equity, social justice, and inclusion, advocating for policies that aim to protect marginalized groups and ensure fair treatment of all. Conservatives emphasize individual liberty, free markets, and tradition, focusing on personal responsibility, maintaining social order, often with minimal state intervention. And then the core values in the last column are emphasizing populism and nationalism, challenging the political establishment, and advocating for policies that prioritize national interests and protectionism. So again, the large language model produced this just by asking the question, and does provide links to why it recommended each things to protect against hallucinations. So I want to thank you for your invitation to share this material and have this discussion. I'm available by email. The LinkedIn page is there, and the reason why I've got that picture, those are my kids, and my humorous quip is that I've got 2 kids. I decided I would raise one with full safety, and that's my daughter here on the right, and then I would treat my son as a control, raise him for 20 years, and then see what I could learn from the experiment. So fortunately, they're both doing very, very well. Neither of them looks very much like this, but they're continue to be fabulous kids that inspire me every day. So thanks for your attention, and again, please reach out if I can help.